Hey everybody, welcome back to the ECG channel. My name is Reid, and don't forget that you can download the PDF of this document down in the description below and follow along and make your own notes. And don't forget to like and subscribe to the page if you enjoy. So let's jump into it. So the first thing we're going to do is look in the forest, and really just what that means is just get an idea of what's going on with this strip. And so if you look down here at this V5 rhythm strip, you notice that I've got a pretty regular complex or narrow complex rhythm, and so that rhythm seems to be regular this entire time, right? So that's reassuring. If I look at the rate, I find a QRS that lands on a solid line, maybe right here. You see my rate is 300, 150, 100. So we'll say 100 beats per minute, right? So right on the borderline, just the minimal criteria for this to be a tachycardia, but it's not too fast, right? So my mind is probably thinking it's probably a sinus tachycardia, right? And you can briefly notice here in V1 that I've got what appears to be some regularly occurring P waves. So let's take a look at my next step of kind of how I go through this and look at the morphology of this P waves. What is the atria doing? And you can see that I've got P waves that are upright in lead 1, and P waves that are upright in AVF, and so that tells me that the P waves are coming from the sinus node, so that's reassuring. Next thing we're going to do is, remember, the AV node captures that signal that's coming down from the atria, and so we're going to take a look at our PR interval that represents how the AV node is doing. And so I find a lead that's got nice sharp P waves. Here, maybe we'll choose lead 2 right here. See our P wave starts in this sort of our QRS, and so my PR interval is probably 4 small boxes there, so 160 milliseconds. We know that normal PRs are in between 120 and 200, so that's normal, but that's only one of the PR intervals. That tells me how the AV node is beating for this beat, but I want to make sure that it's consistent across the board, and so I scan through and I make sure that every P wave has a QRS. I zoom in and I make sure that there are no extra P waves that I'm not capturing. I don't see any, so this is good, it's normal. Next thing we're going to do is we're going to evaluate our QRS complex. In the QRS complex, we said if we looked at the width of it is narrow, right? So my QRS is less than 120 milliseconds in duration, so that tells me that it's rapidly being conducted through the ventricles, which it should be, which is typically through this His-Purkinje system from the AV node, which all makes sense since we have nice sinus P waves and good PR intervals. And that QRS axis is upright in lead 1 and it's upright in AVF, so that tells me that my QRS is generally going down and to the left, which is how it should be going in a normal heart. So that's good. And I look for R wave progression. I see we have some slow R wave progression. I see I have my septal R wave throughout the precordium. It should be growing and growing. So it maybe takes a little bit before it becomes dominant in V4. So we would say maybe some slow R progression. Okay. Making some notes here. Now we're going to look at our QT interval. I like to just eyeball this sometimes. I'll take 2 R waves and I'll kind of find the midpoint. And at that point, my T wave should be terminated by then, which it is. So QT interval looks okay. Now the last thing we're going to do is we're going to look for pathological Q waves, which, remember, pathological Q waves are essentially a QRS complex that begins with a deep Q, and that tells us that there might have been a previous myocardial infarction. And then we look for ST and T wave changes, like ST elevation or depression, to look for active infarction or ischemia. And so you look at the anatomical leads, and what I notice is that my eyes kind of get drawn to leads V3, V4, a little bit of V5. And so what do we notice here? We notice that we've got some pretty significant ST segment elevation. So here's my baseline, and here's my ST segment, right? And here's in V4, so my baseline, ST segment. In V5, you see we have a little bit of ST elevation. If you look at the T wave morphology itself, notice how the T wave is this hyperacute T wave. It's not that kind of T wave, it's this hyperacute T wave where you have more area under the curve, right? And notice that we have that here in V4, very much a hyperacute T wave, and a little bit in V5. All right, so when you have ST segment elevation and hyperacute T wave, these are all pointing you towards some type of occlusion of a one of our coronary arteries. And so we have that in our, what are these leads? V3, V4, V5. These are the anterior leads, right? If I took you to a diagram of our leads, remember that these are all on the precordial, like transverse plane. And if you notice right here, V3, V4, V5, what are they capturing? They're capturing the bulk of this anterior wall of the myocardium, right? So anterior wall, okay? So we have evidence of anterior ST segment elevation with a little bit of lateral involvement, but not so much. And that might explain why we have this poor R wave progression, right? Because we have myocardium in this region that is having a difficult time conducting tissue because it's in the middle of an infarcting event, right? And so you look for reciprocal changes. You're like, okay, maybe I've got some reciprocal ST depression here in my inferior leads, especially maybe lead 3. You can see maybe a little bit of reciprocal changes. Or maybe here a little bit. It's hard to tell. Anterior leads don't always get the best reciprocal changes. So let's put this all together. So what do we have? We have a sinus rhythm at a rate of 100 beats per minute with anterior wall or anterior lead ST segment elevation with hyperacute T waves in leads V3, V4, and V5. And so we know that the anterior portion of the myocardium is supplied by the left anterior descending artery. This person's having an LAD occlusion. So I hope this helps. If you have any questions, feel free to put them down in the comments. And if not, thank you so much for watching, and we'll see you on the next ECG video. Have a great rest of your day.